We are absolutely thrilled to welcome Heather Frieden from Navigating Onward to talk about understanding self-harm and suicide risk in children and youth. We have come to know Heather as a strong advocate in our community for suicide prevention, intervention, and postvention. And today she offers us her exceptional knowledge, her depth of experience, and professional expertise so that we can better understand the needs of our children and youth and what to do to support them. So Heather, we thank you very much for joining us, and we're happy to turn things over to you now.
Thanks very much, Tiffany. If people can be just patient with me for just one moment, I'm going to share a slide. See, there it is.
How does that look? Can you see that now? Yeah,
It looks like it's
perfect.
loading.
It
So
is.
there we
Great.
go.
Perfect.
Fantastic. I always feel much better when the technology works and my slides are up and we're rolling. So that's great. So again, thank you for the very kind introduction. So I'll try to just set the stage in terms of what we're going to walk through tonight. Again, just a reminder around privacy. If you need a moment to situate yourself in a private place, this is a sensitive topic. So just wanting to acknowledge that on the outset. Please take care of yourself as we move through the material this evening. And I will answer, just as Tiffany referenced, we'll do questions at the end. I'm hoping that as the slides unfold, some of your questions might be answered. And there's just lots of material. So we thought it might be best to kind of move through the concepts and then leave some space at the end for questions. So thank you for the kind introduction. This is me. It's always a little bit odd when you see a photo of yourself on the screen. I will say, just in terms of my philosophy, so I'm a registered psychotherapist, but particularly on this topic, it's so important to work collaboratively and as a community. So I was very pleased when Tiffany and Caitlin reached out to have a conversation about this, I think, really important and timely topic. And you'll see as the slides unfold, we don't view those of us who are engaged in the community around self-harm and suicide prevention, we don't view it as an individual issue or an individual problem. It's very much about community and a collective approach. And I'll try to speak to that. So I try to live that in the community work that I do and the individual work I do as a therapist with children and youth. So that is me. I'll move to our agenda. So just so folks have a sense of what we're going to walk through tonight. So again, I think I've shared my self-care reminder with folks. I do always practice from a trauma-informed care lens. I'll talk about what that means as it relates specifically to self-harm and suicide. But that is an approach I think that more and more we're integrating to many of our systems, many organizations. It's just an acknowledgement that often children and adolescent behavior can come from a place where they may be feeling hurt, they may be feeling unsafe, and it's just a shift in how we view behavior. So we're going to talk about the importance of building relationship as it relates to self-harm and risk. We're going to talk about risk factors, protective factors, and warning signs, and that's sort of the core framework of what we're going to walk through this evening. We're going to talk about evidence-based safety plans. So for those of you who might have worked with a therapist before or had some contact with a hospital or other care providers, you may recognize safety plans, and they're an approach that many of us are using to support families, children, and youth in the work. Okay. So again, as I was saying, we have a public health view of self-harm and suicide, which again is a little bit different. So I'll sort of give a little bit of background. All of my training is in psychology. And I very much value that. Psychology offers us a lot, gives us understanding, gives us tools, gives us an ability to intervene when people are feeling distressed. But there are some limitations to psychology. Psychology has a habit of viewing the problem within the individual. And actually, I would argue that social work sometimes is a little bit better at understanding the social context. So I tip my hat to my social work colleagues And so we don't want to just locate the problem within the individual. We know actually that there are other sources of distress for children, for families that are sort of driving the bus, so to speak. And we don't want to just locate that with that individual child or adolescent. So that is sort of the shift in our thinking. I don't generally spend a lot of time talking about stats, but I do think it's really important to understand that this is an important issue for young people. We know that rates of suicide and self-harm are younger for transition age youth. So when I work in community, we often talk about 12 to 24. We try to have a very broad range, but we know that this is a really important issue. The next slide I have to create a little bit of context for us, and this also speaks to the public health issue, is that we know that we have children and youth who are presenting at emergency departments who haven't received care in the community. So this is not, about critiquing the hospital or critiquing any one person, but it tells us that there are system problems. Because what happens is if you can't access mental health care in the community or with your family doctor or with a local social worker, we are very concerned that the acuity, right, the level of distress for young people is growing. Then we have a crisis, and then people are accessing emergency supports. And that's really not where we want things to be. We want to be intervening much sooner when children, youth, and families are telling us that they are feeling distressed. So again, we very much have a system issue. The other piece that is really important, or much of the work that we do in community around suicide prevention, is really encouraging people to speak openly about the issue of suicide. So it can be, if you're new to the issue, really challenging to ask the question, to talk openly about things like self-harm, mental health. We know that there's still significant stigma in our community. And I'll explain in a moment, I think trauma-informed care really helps push back against that stigma, and I'll explain why. But just to draw your attention to some of the language pieces. So historically, actually, suicide was considered a crime. So it's why we're really moving away from saying that someone committed suicide. We talk about someone has died by suicide, someone has made a suicide attempt. And we certainly don't want to minimize or trivialize someone's distress by saying they're just attention seeking. That would be minimizing. We always want to take any expression of harm very seriously. And so it is not about being self-centered. It's not about being manipulative. Really, suicide and self-harm is an expression of pain. It's a behavioral expression of pain. And so we want to just be careful about the words that we choose to describe that. So we want to ask people openly and directly. So I would encourage, all of you to have those frank conversations, but also to think about how you might craft those questions. So this is something as a therapist, I'm always thinking about, how am I framing the question? How am I stringing my words together? Psychotherapy is very much the art of language. And so we don't want to ask someone a question like, you're not thinking about hurting yourself, because it implies a no. So sometimes it's just about being aware that sometimes our own discomfort can come through. And if we could take a moment, take a breath, ground ourselves, and then have the conversation, I think we're much more likely to have, someone that we care about be able to have a more frank conversation with us and disclose. So this is the trauma-informed piece that I want to talk about as it relates to suicide and self-harm. And this is the fundamental paradigm shift that I think we're working at this across mental health and across education, across health systems. Our old way of thinking, and again, psychology, has a bit of a role here where we would sort of think, where's the problem? The problem must be with the individual. What's wrong with you? As opposed to sort of stepping back and thinking about the context, what might have happened to this individual, to this child. It's a very different way of thinking. So trauma-informed care is not, it's not about tools and strategies. It's actually about a paradigm shift, thinking very differently, a different approach. Because as a therapist, I would share that nobody ever comes to me on their first appointment and says, Heather, I've had some stressful experiences and I'm here to receive support. Nobody ever says that. Everyone always comes in and says, I think there's something wrong with me. I'm not doing X, Y, and Z right. I keep doing, and so it's always, people always sort of burden themselves with, there must be something that I'm doing. And so we certainly don't want to view suicide or self-harm in that way. We want to have, we really want to understand the context in which, children or youth or individuals are experiencing that pain and how they might be looking for ways to cope with that. So even the Mental Health Commission of Canada says that it's really important that we continue to integrate this trauma-informed approach. So I'll just pause here because I don't want people coming away thinking that everyone who engages in self-harm or has thoughts of self-harm has experienced trauma. Trauma is a bit of a complex word and people use it in different contexts, but I would say that we can feel very confident that if someone is thinking of self-harm or has self-harm, that they're experiencing emotional pain. I feel very confident to say that, and they've had some significant stressors. So it's not that we want to jump to conclusions, but we want to recognize that there's likely some significant stressors in the life of that child or young person. The other piece that I think has really helped us contextualize and view things from a public health perspective is the adverse childhood experiences research. So it's very easy to find information if you're interested. You can certainly Google and read more. But essentially what they did was they looked at stress and adversity in childhood, and then they compared it to adult health and mental health outcomes. And I think a lot of people thought, yeah, if you have a major stressor as a child or an adolescent, I don't think people were surprised to see that that might result in anxiety and depression. That didn't really surprise people. What surprised people was, let's see if I have it on my next slide, that it can impact your health. So that you can struggle to manage your weight more, you are at higher risk for things like COPD. And so we want to really, again, this is the public health piece, instead of just sort of saying to people, you know what, you're having a health problem or a mental health problem because you're not taking good care of yourself. You're not making very good choices. You're not exercising, you're not eating right. And that's why you have health or mental health issues. We want to say to people, there are significant stressors often in the background that are impacting people's neurobiology. And I find when people sort of learn that piece of psychoeducation, it takes the pressure off. Like, it's not about sort of pointing fingers at people. It's about understanding our stress response, essentially. So I'm going to show you this next slide because I think it's helpful at framing that. So whether you experience stress or anxiety or trauma, something big that has happened, and I'm not trying to create a hierarchy of difficult life experiences. So if you experience something that was really challenging for you, what often happens in the stress response or the anxiety response that we know is that your amygdala is activated. So there's more information now about the stress response and neurobiology, what's happening in your brain. So for all of us, whether we're an adult or a child, that amygdala in your brain gets activated and you can move into fight or flight. And here's the tricky thing about being human. We are not very good at distinguishing between everyday stressors and life-threatening events. So it's all the same response, which makes being human really complicated. Whether it's the unknowns of COVID or my taxes are due, true story, my taxes are due and I'm stressed, I then move into fight or flight. And what happens when that part of my brain gets activated, my frontal lobe shut down. there's actually lots of evidence to tell us that when you are sort of worried about your security in the world, we don't, that's what we focus on. We actually turn off that part of our brain that is engaged in problem solving, in reflecting, in being creative. Our brain says, you know what, we don't need that stuff. We just got to focus on getting through. And so the other piece that can happen, if that's happening quite a bit for us, it can make it harder for us to, especially if we're an adolescent, we're developing and growing skills, or a child, can make it harder for us to develop those skills around impulse control, or emotional regulation, or managing big feelings. That sort of trajectory of learning those skills can be interrupted if we have big stressors in our life, that is sort of chronically activating that fight or flight, or that stress response. So that is the big piece that we've learned from that. And we know that that translates and connects to suicide risk for adolescents and self-harm. That can be the pathway. So I don't like to talk in absolutes. It's not always the pathway, but it's often, or it's a way of understanding how that can come to be. So again, there are sort of these impacts for brain development, right? Your ability to regulate your emotions, behavioral regulation as well, your concept of yourself, if you're always sort of under threat, that can impact, or if you've internalized. Children, almost always, if something stressful happened, if something bad happened, I must be bad. And it's part of child and adolescent development. And so we want to take those opportunities, yes, to rescript that and to listen for times when we might have internalized something like that. And there's a very good developmental reason why we do that. It actually gives us a little bit more sense of control if we think, oh, if I just work a little bit harder in math class, I won't feel so stressed, as opposed to going, boy, it's really hard to learn math online in the middle of a pandemic, because that doesn't give us such a sense of control. So we tend to internalize and take more responsibility for things. So I think this is an important slide. The reason that I chose to include this is because I worry that sometimes we go to the place of thinking that all stress is bad, and that is not the case. So it's good to see things in a continuum. So positive is that it briefly increases our heart rate. We get that little bit of, stress hormone rolling in our body. So for a great example would be for tonight, feeling a bit of nervousness about presenting. There's that nervous energy, and that kind of keeps me on my toes in terms of, presenting and thinking about different ideas. Totally normal for kids to be nervous about the math test. Totally normal to be nervous about, the first soccer game, meeting all the new kids. Those stressors and challenges help us grow and build skills. So growth is uncomfortable, and it's kind of like just sort of accepting that's part of the process. And we're going to feel a little bit of anxiety. We're going to work through it and continue to grow. The next level is that tolerable piece. So again, like, we can have a challenge that comes along, but again, if we continue to work on, our school environments, our community environments, and we buffer and support children in managing these things, I think we're all working very hard to make the pandemic tolerable. And layering on those supports. So it's a bigger stressor, so we layer on more supports. What we don't want for children and youth is the last one, where there really isn't enough support to manage big things. And they really are outside of what we should be asking children and youth to manage. And again, without those supports. So this is really critical. It's the attachment piece. So the more I learn about attachment, the more I look at the research, it really tells us how important the relationship piece is. And this shows up in psychology and psychotherapy as well. And so For those of us who are engaged in counseling, we went to school to get that training. Here's, the piece of research that, it's like letting the cat out of the bag. It actually doesn't matter whether I use cognitive behavioral therapy or narrative therapy. It's the relationship that I have with the adolescent or the client that I'm working with that is actually going to drive change. So we know that one of the best strategies that we have to help people feel heard, seen, understood, more secure, reduce their stress is the relationship or the attachment. And attachment is the primary regulator of emotional arousal. Okay, that is what helps us feel less stressed. And so sometimes when I'm presenting, I will ask people just pause for a minute. If you think about your work environments for a moment, think about who do you connect to. This might be happen on a bit of an unconscious level when things are not going well at work. So I know I have a person, she's about 3 doors down right now. I go and knock on Delisa's door when I'm having a rough day. That's attachment actually, because I know she's not going to judge me, she's going to shore me up, she's going to encourage me. We have a good relationship. I can predict how she's going to respond. That's the attachment piece. And so sometimes there's a bit of a misnomer around emotional regulation as it relates to attachment, and I'll explain what I mean. Occasionally, I will hear people say that child needs to learn to regulate. I think they've really missed the concept around that. And it's not that I'm trying to be critical or point fingers, but they've missed the boat. What that child needs is more opportunities to co-regulate in order to internalize the skill. It's not something you learn by yourself, I would argue. And so again, it is about the environment, if you will, or the context. And so it's not about putting it all on the individual child or adolescent. Again, it's through relationship that you internalize and acquire those skills around emotional regulation or distress tolerance. So let me look at the next piece. I'm going to confess, the only challenge I have is the print is really small on my view. So I might have to pause for a minute to see what I wrote. Okay. So there is a model. So I do have training in dialectical behavior therapy, so for anybody who has maybe sought care for a child who might have had a risk around suicide or self-harm, that is often the go-to. So I have some more slides that talk about what do we know are helpful strategies. And I really like the biosocial model that is part of DBT because it really says that there are some factors, and I like the way the psychologist that created DBT explains this. She talks about how sometimes some of us are more emotionally sensitive. And I worry a little bit about using that word sensitive because sometimes it's used to minimize, oh, that person is just really sensitive, but that is not what I mean. So I have a colleague that explains it in this way that, some of us have skin sensitivities and food sensitivities. Some of us are more emotionally sensitive, meaning that we experience the world like we're a sponge, right? If other people are upset, it's really hard for us to create a boundary and just separate ourselves from that. It's like we take on more empathy, more emotions. Even if I think about my own children, my son always takes longer to settle if he's been upset. Doesn't mean he doesn't have a legitimate reason to be upset. It just seems to be how his nervous system works. It takes him a little longer. So that is kind of what we mean by that emotional sensitivity piece. And so if that is part of your neurobiology and you have a stressor and you don't have sort of the right supports at the right time, this is part of what can lead to distress for some children and youth. And so they offer a good explanation around this pathway to dysregulation. So I'm going to talk a little bit about self-harm right now because when we talk in psychology, when they talk about self-harm, they often talk about direct and indirect. So the most classic sort of example of self-harm is someone cutting themselves. And that, again, is an expression of pain. It's an attempt to cope with that pain. We know that when children self-harm, there's a release of endorphins that happen. Sometimes people will tell us, well, it's a way that I can express my pain. And I would argue that it's a behavioral expression. So if you think about child and adolescent development, the older we become, the more capacity we have to express ourselves verbally. When we're younger, we tend to act out, right? So if a child is overtired and they're 6 years old and you have to get groceries and it's 8 o'clock at night and you're trying to get home and maybe you're just at an activity, it's not likely that that 6-year-old at the grocery store is going to turn and say, I'm really exhausted and I'm getting cranky, right? That would make parenting really easy if 6-year-olds would do that, but they don't. They behave in ways that tell us that they're overwhelmed and exhausted. So they do the starfish temper tantrum at the grocery store, right? So I don't mean to like be so lighthearted in talking about such an important topic as self-harm, but what I'm trying to express is that kids are more behavioral and we have to pay attention to their behavioral cues. It is not until you're older that you're able to articulate, here's how I feel, here's what's going on internally for me, and really express that in a more direct way. And this is why children and youth are more vulnerable because they're learning that skill as they get older, I would argue. The other piece that I didn't want to miss out on is I didn't want to just talk about self-harm and just sort of make that assumption around, the cutting piece, which is very common and it's what people talk about most often. But to understand that self-harm, we can have a more broad view of that, that sometimes children are using, what they're eating or not eating, or substances or risk-taking behavior. So I'll give you an example of that behavior piece and the risk-taking. I was talking to a 17-year-old boy, this was last year, and he was articulating to me that he was struggling with some feelings of anger, and he was driving a vehicle, and he ended up getting in a fender bender, but he was talking about, it felt so good to drive that car fast when I was angry. And he expressed to me afterwards, he goes, but I also realized at that moment how important it is. I've got to start talking about my anger. I can't get in a car, drive fast, get a fender bender. Like this is just not making sense. So he was able to step back and kind of look at the dynamics of what was happening. And so one of the things that we know for children who self-harm is they have a hard time and are at risk for suicide. They don't express their emotions quite as easily, right? They're internalizing things more often, and we really want to encourage kids to name, identify, and express their emotions. So one of the things, I guess one of the takeaways I'm hoping that people will have is also to understand that some of the skills and responses are not as complicated as sometimes people imagine them to be. We can sometimes feel very overwhelmed by self-harm or someone having thoughts of suicide, but actually the skill underneath that of naming and expressing your emotions and connecting and building relationships, help seeking and reaching out for support, those are not overly complicated interventions. We just need to make sure that, that child gets connected at the right time and the right fit. So again, some of the differences that we see, sometimes children will talk about their own self-harm and they'll articulate that it's really about wanting to feel better. So there's nothing wrong with asking. It's actually really important that we ask directly, are you having thoughts of suicide? Tell me about the self-harm. What are you thinking at the time that you're hurting yourself? So for those of us who work in mental health, years ago, there was sort of this push to not confuse self-harm with suicide. And I remember receiving some of that education, right? Don't assume that everyone who is self-harming has an intent around suicide. And a little bit of a concern that sometimes we were overreacting or misattuning to the clients that we were working with. And there's some truth in that, but I would also say that I feel like we pushed a little too far in that direction. We do want to understand there is a relationship between self-harm and suicide risk, and we certainly want to address that and make sure that a child that's hurting themselves isn't at risk and addresses that and doesn't sort of move in that direction. So simply put, we don't want children getting comfortable hurting themselves. That is really important to address that piece because it does open the door to suicide. So it follows the principles of exposure therapy, right? So the more you do something, the more you can get comfortable with it. So we want to pay attention to that dynamic around self-harm. We certainly don't want young people getting comfortable cutting themselves. It's very high risk. And sometimes I hear that from adolescents. Well, it's not a big deal. My friends are doing it. This is normal. It is a big deal, and we need to address it. And that's part of the reason why. Because it can increase risk. So there is research that tells us that self-harm does increase your risk for suicide attempts. So we really want to take that very seriously. So I think I'm just going to take a peek at my slide. I think I have spoken to these ideas. Yes. Okay. So we don't want that self-injury to be a rehearsal for suicide or a rehearsal for more serious self-harm. So we certainly want to address that. The other pieces as we get into thinking about risk factors is there are mental health challenges that are more likely to be associated with suicide risk. And number one on that list is depression. So we certainly want to be supporting young people who are experiencing depression and getting them connected to care. We know that psychosis, schizophrenia, those things also, we certainly want to address that and assess risk. Bipolar and substance use disorder. Now, the piece that I just want people to be careful about, and I think we're getting better across systems at understanding this, we never want to assume that because the depression was addressed, right? So let's say someone accesses medication, they're working with their family doctor, and they're feeling better, but they've expressed some thoughts around suicide. We never want to assume that addressing the depression will automatically resolve the suicide risk. That's a danger that we just don't want to go down that road. And there's actually not any evidence to tell us that that sort of simple treatment pathway is helpful. We know that suicide risk needs to be addressed directly and needs to happen in counseling, in psychotherapy, through conversations and building skills. So it's a both and sort of response. I wanted to include this slide to help people understand that it is not unusual for people to have thoughts of suicide. And so again, it just reinforces that we need to be asking. We know, and this data is true for both Canadian data and American data. That tends to be the range, whether you're looking at the Center for Disease Control in the States or you're looking at CAMH here in Canada. We know roughly that 10 to 13% of young people have had those thoughts. So we want to be asking, we want to be proactive. So we're going to look at risk factors. Okay. And so again, given that context around trauma-informed care, you won't be surprised to see some of the items on the list. We know that sexual violence, sexual assault, harassment, or experiences of violence or bullying, emotional abuse, those things are related. I've highlighted a couple of pieces, depression and anxiety that persists. And I'll explain why I've highlighted that because it's connected to the other pieces. Whether you're a child or an adult and you experience persistent depression, you start to feel hopeless and you can start to feel like I can't change this. So that's why we really want to intervene as early as we can so that young people can learn skills and they can feel like they can navigate and influence their own mental health. That is really important because we know that hopeless, helpless, worthless is very much correlated with suicide risk. So we want to be listening for that. It's really important that young people feel good about themselves and that they have feelings of effectiveness and that they're able to see some positive outcomes in the future. That's hugely preventative. We also know that environments are part of that risk factor. So this falls under means restrictions. So you'll see access to lethal means. So we know that environments where young people don't have access to medication, where they can't walk to the corner store and access alcohol, those communities are safer. And so that means restriction is very much tied to that public health view of suicide prevention. You know, what's available in our community? Because that impulse or that thought of suicide always passes. No feeling lasts forever. And so it's really important that we create some space between the thought and what might be available at arm's reach, right? We want to increase safety by reducing access to things that might hurt us. I'm just going to look at my list here to see if there's a couple other things that I haven't spoken to. Certainly, history of suicide within the family or peer exposure. So this is an important question that I think we all can be sort of cued to ask. Do you know anyone who has made a suicide attempt? Do you know anyone who's self-harming? Do you know anyone who has died by suicide? That exposure, we know from the research, creates distress for young people. And one of the things that we know is that even if a young person doesn't know the person who has died by suicide, just knowing of can increase distress for young people. So we want to have a more proactive approach in our community where we ask, where adults are reaching out and we are asking the question rather than waiting for young people to self-disclose. I actually think that that is not not a responsible response to what would be child and adolescent development. We need to be asking, not anticipating that they're just going to disclose and tell us. We need to be the ones that sort of take the lead on that. We know experiences like rejection, failure, humiliation, loss, those things can create significant pain. And so that's why I would encourage people to have a little bit more flexible view of stressors for young people. And again, this is where it gets a little bit complicated because I find sometimes we're using the word trauma a lot. I don't know if we always pause to ask, you know, what does that mean? But ultimately, it's, you know, what is painful for that child? What have they experienced that's distressing? We don't want to be sort of making that determination. Oh, well, if I experience that, that would only bother me for a day or two and I would be fine. We don't want to minimize that because we don't know the internal narrative. We don't know what that young person is telling themselves about themselves in response to that stressor. So we really want to be listening and be attuned to what they're telling us. And I'll just draw your attention to the last item is perfectionism. This actually came from Western in our own backyard. They did some research and young people who feel a lot of pressure to perform at high levels, to be perfect, it's like being on the never good enough treadmill, actually. And so we want to be paying attention because sometimes we can all have bias as it relates to self-harm and suicide risk and mental health. We have notions of, you know, who might be struggling and who's okay. And actually, you can have someone who can be doing brilliantly in school and, you know, be on, you know, an all-star on all the athletic teams. And this can be sort of underneath the surface if we're not sort of asking questions and checking in. So certainly mental health can impact anyone, and we don't want to make assumptions about that. So I've got a few more slides that speak to risk because there's some researchers that have kind of looked at what are the themes related to suicide risk. And these are some of the things that come up. So people will not have an orientation to the future. So that is something to listen for, feeling like a burden. You won't be surprised to see on the list pain, a lot of emotional pain, feeling helpless, feeling powerless, feeling isolated. We know a huge protective factor is feeling connected, having a sense of belonging. And that's where, as a community, I think that we can create the conditions that promote community well-being and reduce the likelihood that someone is going to feel this way. Feeling stuck. Sometimes people will express, I just feel like I can't do anything. I feel stuck. Those are some themes that are associated. This is a researcher from British Columbia, Dr. David Klonsky, and he also talks about feeling like you're in a lot of pain. And that's where earlier when I was referencing those skills around emotional regulation, one of the things when a young person is coming for psychotherapy and they've had thoughts of suicide and they're experiencing a lot of emotional pain, that's often one of the first skills we go to is emotional regulation. What can you do to reduce the intensity of that feeling by a few notches so that it's more manageable? And feeling more hopeful that you can manage and navigate that. So we know hopelessness is associated with that. Feelings of a connection or loss of connection, we know that's part of it, and the capacity for suicide. So what he means by that is related to that means restriction piece. Do young people have access to things that can hurt them? Are they familiar with things that can hurt them? And so we want to reduce that accessibility. This is another, and I've just finished this past year training from Dr. David Jobs. He's an American psychologist. He's done research for a long time, and he started actually in universities and colleges. So with that transition age youth population. And again, I know this will be a little bit repetitive, but I find it affirming when multiple researchers sort of have these common themes and they come through. It tells me that we're sort of on the right track in terms of understanding what might be underneath or what might be driving. So the way that he talks about suicide risk is to talk about identifying the drivers. Let's kind of underneath this idea of I need to escape, I don't want to be here anymore, and thinking about suicide as a solution to that. And so, of course, he talks about psychological pain. He talks about external stressors. He also has this notion of the desire to do something. So sometimes people will have a very strong urge, I need to do something to stop this. Of course, he talks about worthlessness and then looking at other risk factors. And this is sort of his framework for intervention as well. So very helpful process where he has a very structured risk assessment, but then also frames for the clinician the intervention piece. So a framework for intervention and care. So things like support, problem solving. It's very interesting. Sometimes we, again, think that the interventions are really complex. And what we know from the research is supporting young people in growing their problem solving abilities helps protect them from feelings of helplessness. And I think that just is makes so much sense to me. If you can solve problems, if you can navigate, if you can come up with solutions, you don't feel so stuck. You don't feel so helpless. So one of the things that we know that protects all of us in terms of our mental health is this notion of self-efficacy. So I know that's, sort of a bit of psychological jargon, but essentially what it means is our belief in our ability to achieve our own goals, our belief in our ability to influence things, not necessarily control, but influence things. And we all need that for our own psychological well-being. We need to feel like we can access resources, we can influence things, we can express ourselves, we can solve problems, et cetera, et cetera. This is Dr. Thomas Joyner, and he also has some similar things to say, but I like the way that he sort of conceptualizes in a visible or a visual way. And he really focuses on this thwarted belongingness, like feeling alienated. This is why I think those of us, well, all of us, I will say, during COVID, were so worried because it impacted our feelings of belongingness. We were disconnected from our family, our friends, our community, and we want people to have a sense of belonging. Feeling like we're a burden to other people, so I can't ask for help. I'm just going to be bothering Tiffany. I'm just going to be bothering Caitlin. We don't want kids to feel like a burden, so we want to be messaging lots of permission around help seeking and connection. And then the last, he talks about this capacity for suicide. So that's things like access to means. You could also include the self-harm piece in that capacity, because again, if you're getting comfortable with hurting yourself, you're sort of growing your capacity. You know sort of what to access, you know what to do, and we really want to work with young people to distance themselves from that. I decided to include this slide. So this is from the National Truth and Reconciliation. I think lots of people are familiar with, what we've been learning about the history of residential schools over the last few years. It's been very heartbreaking to read more and more of those stories as many of us learn more. This piece of research came from Western Canada, from British Columbia. And I think it's probably the most important example that we have that suicide or suicide prevention work is public health work, that it is about what's going on in communities and how we're supporting people, and it is not necessarily about the individual. So what they did is they looked at different communities, First Nations communities, and they found that First Nations communities where there was more local decision making, more influence over education, access to health care, those communities had lower suicide rates. Communities where the external Canadian government was making more of the decisions, there was less local influence, those communities had higher suicide rates. So again, it just tells us how important it is that we feel a sense of influence, that we can direct things for ourselves, that we can make decisions that make sense for us. And again, that shows up in different communities. There was some very interesting research about high schools in the United States, in the Northwest. And what they found was kids were safer in high schools where there was a culture of help seeking. In high schools where kids were feeling like they couldn't ask for help if a stressor came along, those kids were not doing as well. So the messaging, the culture that we create really does have an influence on our mental health and our wellness. So again, protective factors are things like access to mental health care and healthcare, connection to family, to community, to social organizations. So think about sports. I think sometimes we don't give sports and the arts its due credit in terms of what it means for children to have a sense of belonging, to feel effective in the world, to have those social connections, to have access to other adults. I very much appreciate the piano teacher, the voice coach, and the soccer coach that are in my children's lives. Because you have more adult presence, kids feel a part of things, and they're learning those problem-solving skills, and they're experiencing a sense of belonging. So again, those life skills of problem solving, naming and expressing emotions, coping skills, the ability to adapt to change, a sense of self-esteem, a sense of purpose. Think about what the arts and sports do in terms of giving children a sense of purpose. Cultural and religious practices are also really important and are a protective factor. So again, a few more. We think about sometimes in the literature, they talk about internal versus external protective factors. So again, social supports, supportive school climate, school-based anti-harassment policies, that there's a focus on social justice, or a commitment to social justice, access to care, and access to supportive care providers, support and acceptance, et cetera, et cetera. And I'll note the last one, aftercare, from our hospital system. I think over the course of my career, I've certainly seen more collaboration between systems. If you think about community mental health, education, the hospital, but I think we could do more in terms of when kids transition from one system or one organization to another. Those are really important points to really help kids feel supported. So things again internally, I apologize. I know there's a few things that repeat, but that those interpersonal skills and relationship skills, problem solving skills, feeling effective, feelings of belonging and connection, cultural identity, having reasons for living, that comes out in the research as well. And sometimes there's some interesting work with therapists and looking at how we intervene, and therapists are more effective if they ask kids, what keeps you going? Or ask even adults, what keeps you going? That those reasons for living are really important for us to explore and reinforce. Okay. I think I'm doing okay for time, actually. That's great. Okay. So I want to talk to you a little bit about adolescent development because I do think it intersects with risk. So I'm going to invite all of you just to pause for a moment and think about your sense of time way back when you were a child. So if you remember when it felt like the car ride was going to last forever, or Christmas holidays were never going to come, or I don't know, summer holidays were going to last forever, whatever that is, children don't have the same sense of time that we do, right? Like I feel like I could look at my watch and, thinking, oh my goodness, summer vacation is going to be here tomorrow. Am I ready? Do I have it planned out? Like I feel like life is moving very quickly. Children don't have that same sense of time. And so, and usually that's not probably, it's totally appropriate for their development, except if you're 14 and you're experiencing a lot of emotional pain, your perception can be that it will last forever. You don't have the same adult capacity to say, oh my goodness, I'm having a bad day. I'm feeling really rough. It will feel better tomorrow. Adults have more capacity to kind of create a frame around that. So there are some things in adolescent and childhood development that are totally normal, but can sort of intersect with risk. We do see children and adolescents as having more black and white thinking. So I'm either all good or all bad, as opposed to seeing things on a continuum. The brain is still developing, right? Interpreting social cues, problem solving, anticipating things, impulse control. We all know that kids are growing in their development. And if kids are making quick decisions, but it's related to hurting themselves or they're in a lot of pain, you can see how that can add to risk. We also know that young people are experiencing a lot of transitional stress, right? Moving from high school to college or high school to university is one of the biggest changes that young people make. And just acknowledging, the stress that comes with that. Because I think sometimes, again, we have sort of a flat or one-dimensional view of change. Well, that's a positive change going off to university, but it's a monumental change. It's huge. Think about, your social supports being kind of turned upside down, you're away from home. It is a lot to navigate. And so we just want to pause and think about what it might be the perspective of that young person. Autonomy from family is increasing. So actually, it can make asking for help more complex, right? It's really normal for adolescents to want to do things on their own. We expect that. It's really normal for adolescents to be pushing back against their parents, trying to figure out who they are, wanting to be more independent. But if they come across something that is bigger than they anticipated or is very stressful, then it's like, oh my goodness, do I really want to reach out for help, right? Does that mean I can't do things on my own? And so trying to help them unpack that a little bit, that there are times when it's totally appropriate to get support. And there are other things that, yes, we can support you in being more independent and making more of your own decisions, and not view that like our North American culture. I think we it's overvalued, sort of that independence. And actually, our relationships and support are so helpful. And that actually is what's more likely to make us successful. And we don't need to feel like we need to do everything on our own. I would argue that for adults as well. And again, sometimes young people can feel that they're invincible. Remember that from me when you were younger, bad things won't happen to me. So you can minimize risk in terms of certain behaviors. So the literature talks about warning signs. So that's what I want to move to next. So it isn't, when those of us who are working in the world of risk assessment, it isn't really that we look at risk factors and protective factors and kind of come up with an answer about what to do or how safe or unsafe someone is. It is to help inform supports that we might want to layer on or address or help us ask more astute questions. But this piece is really important to pay attention to in terms of that more in the moment intervention. So we know from the research that there are warning signs that risk is quite immediate. So we know that when young people are really expressing increasing hopelessness, increasing helplessness, and increasing worthlessness, we really need to pay attention and get them to a care provider to have that really critical question and really look at risk assessment. Again, feeling trapped will show up on the list of warning signs. This is a piece I want people to take note of. We have an over association with sadness and suicide risk. And actually, there's quite a bit of evidence that anger and risk-taking is just as likely to be part of the picture. So if your young person is taking risks and you think that does not make sense, they're really angry, it's very appropriate to ask these questions. We know that substance use, alcohol use is associated, right? It lowers your inhibitions. It's part of that risk-taking piece that we talked about earlier. We want to be paying attention to that. Is someone withdrawing from family and friends and isolating? We know that that can be part of the slippery slope of depression. I don't want it. I don't feel like connecting with other people, so I'm going to isolate, and that actually can add to the depression and add to the distress. Increasing anxiety and agitation, dysregulated sleeping and eating, sleeping all the time, not sleeping at all. You can really see when you look at that eating and sleeping, it's a question I ask all the time, that there's this biological dysregulation happening. Dramatic mood swings, no future orientation, no purpose, sense of purpose. I don't see myself having a role in the world. And the last one that I highlighted is rehearsal. We really want to take risk very seriously if someone has harmed themselves recently, they've had a recent suicide attempt, or if they have things to hurt themselves or enact that suicide plan. So if someone says, yeah, I've been collecting medication, it's in my backpack, that is someone that is actively planning. And so we want to really pay attention. Is this person sort of in the idea phase, or have they actually moved from ideas to behavior or planning or action? We want to really note that, because that tells me that they are moving closer or that the risk is increasing. So we really want to pay attention to that. So this is another way that we conceptualize those warning signs. Are they thinking about suicide? We can ask direct questions about that. Is there a sense of purposelessness, hopelessness, risk-taking, mood changes? Those are all signs that we really want to get that person to get connected to care and really ask those harder questions. So I've included this because I want to transition from that risk, protective factors, and warning signs to think about, what are the things that we can do? What responses are helpful? And so this is really key. And young people tell me this all the time, that you don't have to be a therapist to be therapeutic. So we can offer a lot in terms of prevention by providing that warm, caring relationship, that connection, that sense of belonging. And I think there are a lot of people that are working with children and youth that actually don't recognize the prevention role that they're playing. They're doing it, but I don't know that they're always naming it in that way. The contribution that they're making to supporting the mental health of adolescents and children. The value of relationship. This is from Jennifer White. She's a psychologist in Western Canada. And she says, building a strong therapeutic alliance with a young person is only the most important therapeutic work related to, supporting whether it's an intervention or understanding risk. So this is true for those of us who work in mental health. This is true for teachers, for parents. The relationship is really central. We also really encourage a strength-based approach, right? Can be, maybe I'll say tempting when we're really worried about a young person to kind of focus on problems, but we also want to think about viewing ourselves and others from a strength-based perspective. So the belief that every person can make change, and our language creates reality. So belief in change and growth and healing. And really starting with what's important to the young person. I really believe that that's important. What is important to them? What are they looking forward to? What is creating distress for them? And really hearing from them. Validate feelings and emotions. This is a core skill. And again, I hope to take some of the mystery away from interventions. We know that this is very, very helpful. So if you think about even your own responses, if you're feeling overwhelmed, if you're feeling frustrated, if you're feeling sad, and someone simply comes along and acknowledges that, we often, the intensity of that emotion will drop by a few notches. Like that seems really hard. No wonder you're feeling upset. No wonder you're feeling stressed. When people validate and acknowledge that, it's really helpful. The trick that I find that many of us can get tripped up on, life is busy, there's pressure to get things done, and sometimes we just want to go to problem solving, right? So a young person says, I'm upset about this, and we want to just, or a colleague or anyone, family member, and we just want to solve their problem. And I would encourage everyone to slow that process down and acknowledge feelings first. So there's a framework, and I actually think it was on the slide, Caitlin and Tiffany, that, when people were logging in, there was a nice little learn, regulate, connect, safety little triangle. And it very much relates to this as a core skill. So there are other models that talk about relate, regulate, then reason is one way to think about it, or connect, validate, then problem solve. The idea is it relates to what I was talking about earlier about whether it's a big stressor or my taxes are due. We have the same stress response. Our anxiety goes up, our muscles tighten, we get that stress hormone rolling in our body. And actually, we need to come down before we can effectively sort of reflect or problem solve. So this is the piece that validation allows people to feel heard, seen, and understood. It allows people to regulate and then move to the next piece. So I hope that makes sense. I think if there's one takeaway from this is to not underestimate how helpful and important that to validate feelings and emotions. Okay. And to separate. So if a young person is hurting themselves or has hurt themselves, you can validate their feelings without validating the choice that they're making. So to separate those two things, because I think sometimes people worry that if I validate how they're feeling, I'm somehow giving permission or I'm encouraging their choices around how they're coping with that. And you are not. You can say, I want you to engage in safer coping, but I understand why you're feeling so overwhelmed. That makes sense to me. So that's how you sort of parcel it out. I don't know if I'm going to be able to read this slide. My goodness. It's really tight. So this is related to, thinking about how do you respond to suicidal ideation. So you want to ask, what are you thinking about? How often are you thinking about it? What feelings and emotions are present? Those are all really important skills. And I would say any child or adolescent that talks about having thoughts of suicide needs to be connected to care. Doesn't mean it's a crisis in that moment, not necessarily that they need to go to the emergency department, but they need to get connected to care because that is a worry. We don't want to allow that pattern of I'm distressed and overwhelmed, and I'm going to think about not being here to help me manage that distress. We want kids to have a different framework and a different response to that. Okay. This is also really important, the collaborative piece. So we do things with people, not to them. So it's a little bit of a different shift in our approach. Okay. And actually, the other reason, or one of the reasons that we work collaboratively, is if I have the approach with whoever I'm working with that I'm the expert and I have all the answers and I'm going to, do something to someone, it actually can reinforce a feeling of helplessness. Whereas if we're figuring it out together and we acknowledge that that young person has strengths and skills and insight, it actually helps move them forward around those feelings of self-efficacy, those feelings of agency. And so we don't want to reinforce those feelings of helplessness. The other piece to be careful about is power struggles. So I remember working with a young man. He's probably in law school now. He was brilliant, like straight A student, brilliant. And he was feeling not good about the world. And I don't know if I want to keep going, Heather. So he was disclosing some thoughts of suicide. And he wanted to argue with me what a terrible place the world is. And I'm going to say, actually, if you wanted to, you could collect a lot of evidence to argue that. Like, reading the news. We've got lots of problems in the world. Had I decided to argue with him and say, no, the world's a good place, there are no problems, we don't have poverty, we don't have, climate change, we would have actually had a power struggle. And when we engage in power struggles, people actually can dig their heels in more. It can actually reinforce their position. So I hope I've explained that dynamic a little bit. So it isn't that we want to argue with people if they're feeling, really low or they're not feeling optimistic. We don't want to argue and say, no, things are good. We want to understand, where are they coming from and work together with them to have a deeper understanding and to connect with someone. So I think that's an important skill piece. Okay, so this is the last piece I want to do, and I'm realizing I'm a little bit over time, but I think that's okay. So this is a really common intervention just to give you a sense of like what's possible when someone comes for care. Safety planning is almost always the response. And there's really good research. Stanley and Brown were the first researchers to take a look at safety planning. And really what they're doing is breaking down those warning signs. So what does a young person notice about themselves when they're starting to feel distressed? What are those early warning signs? What might people see and hear from me when I'm starting to become distressed? What are those coping skills that I can employ to manage that distress? So are there things I can do to distract myself? Are there some emotional regulation skills and strategies that I can use? And then the last piece is communicate. Who am I going to connect with in a very planful, thoughtful way? So we actually want to, when we're working with young people, to practice this plan again and again. We want to walk through it. We want to create this plan in a very collaborative way, because it's actually very hard to employ something brand new when you're in a crisis. But if you've had practice when you're at sort of a lower level of feeling anxious, it's much easier to integrate. So this is a really intentional way of building self-awareness. So actually looking at, what's going on internally with you, that's a long conversation with a young person. And then building skills, you can spend quite a bit of time there. And then who are you going to reach out to for help, and how are you going to communicate? So really supporting that help seeking. And then these are the last few slides that I'm going to just to give people some ideas about what do we know is helpful from an intervention perspective. So as a therapist, what am I leading into that we know from the evidence is helpful? And right now there's only a few, so it's not like we've got a dozen interventions to choose from. You'll see on this slide, it talks about problem-solving therapies, things that are structured. Those are really important. So we know cognitive behavioral therapy is really effective. And simply, I know I'm being a bit simplistic here, but it's really helping people understand the links between their thoughts, their emotions, and their behaviors, and unpacking that and helping people see the relationship between those things, and then making shifts, which helps obviously with emotional regulation, etc. DBT is a really helpful approach. We also know it's evidence-based, and there's been some very good research for young people around DBT that is really exciting to take a look at. So that is a really helpful, and it's a very skills-driven approach, DBT, which I also think I like that because it pushes back around the stigma. It's not that there's something wrong with a child or an adolescent. It's about a skills gap that we can support them in growing those skills. And so DBT is very, it's run in a group often. It's very skills-driven. It's very child-centered. It's a really helpful approach. And then the last one that I've been learning more recently is the collaborative assessment and management of suicide. And that's CAMS, it's Dr. David Jobs, and he has a very nice framework, and you can actually use his risk assessment model and intervention framework with DBT. So that has been sort of my approach of choice in more recent years, is to use CAMS with those DBT skills. This is a Canadian creation, so I really would like to just reference this too. There are some emerging groups. So this is from Dr. Yvonne Bergman. She worked at St. Michael's Hospital in Toronto and created a group called Skills for Safer Living. Again, love that word skills in reference to mental health. It really is about building those skills. And she has a number of groups happening in Western Canada, so a number of groups for Skills for Safer Living, and they're doing some outcome evaluation, and there's information on the Mental Health Commission of Canada website. So really great to see some Canadian content that's evidence-based emerging. So that is my present
hand up there. Can you give a suggestion as to how you might open that conversation if you're concerned for a youth or a young one?
That's a great question. I always find it's very helpful whenever I go to trainings to hear how people script things, right? So that you then have a script in your back pocket. So I think it's really about, again, connecting first. So finding a way to connect with that young person. Reflecting, I noticed that you look a little bit stressed, or I noticed this is happening. And, one of the things that I am wondering about, have you had thoughts of suicide? Or have you hurt yourself, or do you think about hurting yourself? So we want to ask that question really directly. So sometimes it actually requires us to get more comfortable with it. Because I think if people hear that we're nervous, sometimes the temptation for them can be to withdraw from us, right? Because sometimes we're afraid of what the answer will be. And so we've got to feel really comfortable. And so one of the ways that we do that is by coming to trainings. So, certainly something like tonight, doing more reading. There are other trainings in the community, Safe Talk, Assist. There are lots of opportunities to grow your own comfort around asking those questions. And yeah, just growing your own knowledge and your own comfort level around that.
And then in tandem with that, Heather, I do work with a lot of caregivers who are worried that if I ask the question that I'm, growing an idea or something that did not exist prior to me asking the question. And so because you and I work in a similar field, I'd really love it if you might just be willing to sort of respond to that, and that concern that really is about like deep care and love for our loved ones around like if I ask a question, then maybe it'll make them think about something that they weren't thinking about before then.
There's no evidence that that is the case. Actually, what happens for people when you ask directly about suicide, it usually takes the tension right out of the room and people go, oh my goodness, I have permission to talk openly about this. And they're really not having a conversation about anything that they haven't been thinking about. And so we just know that there's just no evidence to suggest that you are adding to risk by asking and engaging. It communicates to people that you care and you want to understand their inner world. Yeah,
Thank you.
for
Thank you
sure.
so much for letting folks know that. That's so, Heather, for Caitlin and I in particular who do this all the time, it is so very clear that you're an absolute master educator. Um, we are so grateful for your thoughtful and like informative presentation. Particularly discussing a really challenging topic of self-harm and suicide risk in children and youth. And I don't know if you could see, but the whole time I'm taking notes and, taking pictures of your slides and thinking, in new directions. And there is a long and winding learning journey that is always happening for us in the community who are supporting our children and youth with really tricky and challenging things. And so being a member of a community with you, the way we can work together and support one another to care for our kids, and being able to learn from each other just helps us feel not alone, even in doing the work. So thank you so much. And it is so clear to us that you have such a wealth of knowledge, and continue on your learning journey, learning new things, taking new trainings. And we just know that connections with folks like you in our community as advocates is just an essential support for our caregivers. And we can see that by the number of people who have joined us this evening. And so we thank the audience and we thank you, Heather, for joining us. We are so grateful for your guidance about what to consider, and how to support our loved ones in our families, our kids, our children and youth. So thank you. It's a big deal. And it was a really, really excellent presentation for us. So the last slide that I've just put up here is for our audience members. There's my contact information. So as you could see, Heather is able to, guide caregivers and connect with caregivers. Sometimes it's training that people might be interested in. Sometimes it's additional support and individual and personalized support for themselves. So feel free to reach out to me and I can redirect any inquiry you like. We also would really appreciate any of the audience members clicking this link on the slide here, and just giving us a few minutes of your time to provide us feedback on the presentation. This is a series of presentations for caregivers, and so we are always looking for suggestions on how to sort of improve our ability to offer and provide these presentations to the community. And lastly, if you would like to receive notifications of future events, including that we have another presentation for tomorrow evening on another subject matter, then feel free to click the other link there and it will take you right through to our website and the mailing list for you to be able to sign up and get more information about future presentations.
Thank you so much, everybody, for your time.